So I'm just going to get the session started. So I'm very pleased to be able to welcome Dr. Ando to give his talk on a subject dear to my heart, which people know of multimorbidity. So thanks for everybody who's online and everyone who's in the room. And without further ado, I'm going to hand over.
Thank you. So hi, I'm Taka. I'm a visiting researcher from Japan, and I will be here for 1 year. Thanks for the opportunity to talk with you. Hopefully, last we can discuss maybe collaboration idea. So let me briefly introduce myself. I'm an academic GP at Care University, Tokyo, Japan, which is the oldest private university in Japan, but still younger than University of Glasgow. And I'm also a director of Japanese Primary Care Association, which is a Japanese counterpart to the RCGP. And I completed GP training in a suburban area, then returned to Keio to develop undergraduate and GP training curricula. And I received the Best Teacher Award 3 years in a row. And I completed MPH and PhD at Keio University. But still, I was the only primary care researcher at my university. So I felt I need to strengthen my research skill more, and I want to build a research network internationally. So that's why I'm here right now. And I came to Glasgow with my wife. She's also a GP, and our 2 children. So we are really open to invite social events. So yeah. I like tennis, beer, and whiskey, but I'm getting used to cold weather. Okay, so let me explain the situation of general practice in Japan. So general practice is quite new. So it was recognized as a national specialty in 2017. But before that, the JPCA, the Academic Society, led training program, and it was started 20 years ago. So currently we have 1,300 qualified GPs out of 340,000 physicians. So now only 2% of medical graduates enter GP specialty training. That's a quite low number. So we are trying to increase the number of GP right now. So at my university, Department of General Medicine was established 10 years ago, just after I graduated. So when I returned 6 years ago, I was the only formally trained GP, and I was really, lonely. But now we have 4 faculty members and 6 GP trainees. So we are gradually expanding clinical service, education, and research. And also, I want to explain the primary care system in Japan. So we don't have a registered system, and we don't have a GP workforce. So primary care is provided by the specialists. And also, Japanese health insurance guarantees free access to any healthcare. So people can go to secondary care directly. So especially the people with multimorbidity, they see a lot of specialists at the same time. So that's the situation I went polydoctoring, and that's the main theme of my research. So my main research interest is multimorbidity and care fragmentation, especially polydoctoring in Japan. And I also have conducted some health policy evaluation and regarding medical education. I have done research about the vaccine subsidy during the COVID pandemic. And I also found some inequality regarding the access to the vaccine and also the price. And I'm also doing the research evaluating the curriculum of GP and see what they learn from our clinical curriculums. So, but the main theme is to explore the effect of polydoctrine on mortality or other health outcomes in older adults with multimorbidity. So polydoctrine can affect maybe polypharmacy, and maybe it leads to frailty or care dependency and this, yeah. So I have done several studies regarding polydoctrine. First, I developed the measurement of polydoctrine, and it was associated with fragmentation care index, which is commonly used in other countries. And I also found polydoctrine is associated with polypharmacy and healthcare costs. And second one is I looked which condition is linked to the polydoctrine. So eye diseases and musculoskeletal diseases and prostate disease are associated with increased polydoctrine in Japan. And I also looked the association with mortality. So polydoctrine is associated with decreased mortality among people who have only 2 to 4 chronic condition, which is kind of moderate multimorbidity. But those affected was attenuated among the people having 5 or more chronic condition, which might be a severe multimorbidity. And I also found that visiting 2 to 3 medical facilities is associated with lower avoidable admissions, which is kind of ambulatory, which is called ambulatory care sensitive condition. But visiting 5 more facilities is associated with increased avoidable admission, which means there might be kind of suitable number of polydoctrine. So here I have an access to the Japanese cohort, so I explain the cohort. So this database is called DESK database, which is commercially available database in Japan. It contains large-scale health insurance claims database, and it covers multiple insurer types across Japan. And there are several types of insurance schemes, so I will explain in the next slides. And observation period is about 10 years. So it is just a claims data, so we don't have much patient background. That's a weak point. So measurable outcomes are outpatient visit, healthcare costs, and hospitalization and mortality. So so we have national universal health coverage by the health insurance system. Historically, health insurance system in Japan was started in the kind of employment based. So people who is in employment are covered by the insurer run by their company. There are two types of kind of employment-based insurance, which is for the large company and for the small companies. And for the people self-employed or non-employed are covered by the national health insurance, which is run by municipalities. And the people over 75 all of them are covered by long life medical care system, regardless of employment status. So we have 6 million population over 75 years and nearly 12 million people over below 75 years old. So the common chronic conditions are hypertension, dyslipidemia, and musculoskeletal disease. So my research idea while I'm here in Glasgow, first one is describe multimorbidity epidemiology and trajectory using harmonized definition between Japanese cohort and a UK cohort. Maybe I'm gonna use CPLD or UK biomarker. We are planning to cooperate with Danish team as well. So this is the prevalence of multimorbidity by the age groups. So it shows the similar trends like as UK data, but interestingly, the prevalence of multimorbidity peaks at around 85. Maybe it is due to the survivor's bias or under-recorded due to the older people tend not to visit medical facility. Those are the prevalence of each conditions. So hypertension, diabetes, coronary heart disease, heart failure, those kind of cardiovascular diseases are pretty common in Japan as well. But maybe difference is depression is not that common in Japan compared to UK. So now I'm looking the first chronic condition, which is initially developed in people without any chronic condition. So this is kind of preliminary data, so I need more refinement of the kind of definition of those conditions. But interestingly, so painful condition is really pretty common. And also we now can see the difference between the age groups. So younger generation has asthma as a kind of common disease condition, and the middle-aged have hypertension increase, and oldest population has dementia in those top 5 conditions. And I also looked the top 5 common combination of first and second chronic conditions. So in the younger population, asthma, COPD combinations are pretty prevalent. And in the middle age, diabetes, hypertension, and cancer to painful conditions are very common in those age group. And interestingly, in the older population, heart failure to hypertension combination is very prevalent. So usually hypertension develops first prior to heart failure, but maybe it suggests that hypertension is underdiagnosed in those older population, and then finally develop the heart failure, then they get heart disease. So still, it's kind of simple analysis, but it shows interesting insights, and also I'm planning to do the same analysis in the UK cohort and Danish cohort, and I'm excited to see the difference. So I'm looking for collaborators interested in comparing Japan and UK, maybe in terms of multimorbidity trajectories or care patterns, polydoctrine and GP-led continuity or gatekeeping system. And I'm also interested in the health system evaluation, like health economic analysis. So I'm very happy to discuss any idea about collaborating. Thank you for listening.
So any questions? I'll start looking the room first, and then I'll look for online, if we maybe shrink that down so that I can see the online people. Jen and then David.
Hello, nice to meet you. I'm Jen Louise, I'm a nephrologist, academic nephrologist in Glasgow. I noticed in one of your slides that the prevalence of chronic kidney disease was only about 0.3%, seems probably 10 to 30 times lower than I would probably expect in such populations. So my question is whether you've got biochemistry data in Japan to be able to, because I know we've got the GRD and biobank, to be able to pick up biochemical chronic kidney disease rather than diagnosis.
Yeah, thank you. Yeah, chronic kidney disease is kind of really important chronic condition, and so the answer is we don't have kind of biochemistry data on, because this is Krebs data, so we can find chronic kidney disease based on the blood test. We just find claims, build diagnosis. So I think this is kind of underreported.
So can I just ask, just following on from that,
Yeah.
just interject, because you said on a subset there was more detailed health information. Do you have further information in a subset? That's what I was wondering. I mean, would you have lab results in a subset or not?
Yeah. So people who took a health checkup, then we have the lab data, but those are kind of biased. Those are highly educated or in the higher socioeconomic status takes health checkups. So.
But I'm just wondering if you could look at that data. How many people are in that? How big is that data set?
Actually, I haven't seen yet.
Yeah.
So, yeah.
Because I was just wondering if you could even look in that bias data set, because if you got it way higher, then it would give you an idea of your margin.
Yeah, that's
David.
Hi, David Spencer, Public Health. I was going to ask a different question, but actually following on from Francis' one, your subset data there, presumably you have the patient background variables of those people as well. Because you could reweight that population to make it more representative of the general population. You know, so the selection bias points to bands, including the insurer and even some of the outcome and observational data. In fact, between the two, you might be getting a picture. But a question I had was, I know that you have major pharmaceutical companies in Japan, like Takeda and What's their role in the kind of Japanese healthcare infrastructure?
pharmaceutical companies' role in primary care.
Or just in general, just
I don't know if I catch your intention, but the pharmaceutical company does provide a medication to the market. They don't. Sometimes they negotiate the price to the government, but
I guess what I'm thinking is I would guess that the specialists might be more likely to prescribe the newer agents. Maybe people in primary care. So I guess I was just wondering about how much of the way that healthcare is structured in Japan is influenced by.
I think that's the problem. Yeah, especially older doctors get the information from the medical reps from the pharmaceutical company, especially in the university hospital. So, but yeah, I think that happened. Yeah.
I'm going to see if I can just look on, maybe just end their hands.
Yeah.
Is there anybody online who has a question? Or is there anything in the chat? Okay, I'm going to just ask you some questions in relation to that. So you pointed out that depression was low. Do you have prescribing information? Because wouldn't that be so? When you say the conditions, is that just based on ICD codes or something, or did you take into account prescribing?
In this data, we both count the coding and also prescription. In Japan, it's a billing data, so we cannot prescribe without billing code. So usually the finding the disease with the code is overestimate, and counting the prescription is underestimated. The real prescription.
But then in the UK, we have often found that depression might not be as well coded as it should be, but if you look at SSRI prescribing, you get a better idea of numbers. And I just wondered if you had used like SSRI prescribing to see whether that matched your prevalence of depression. I mean, I guess I'm wondering, is it an artifact of poor coding, or is it just that people aren't being prescribed or treated for it?
The SSRI prescription, the number would be lower than this.
Right.
Yeah.
Okay, so that's interesting. I asked her.
Thanks, Naga. I'm really intrigued by the model of healthcare service and you sort of bypass primary care, or there is no primary care as such. So it sounds like a lot of focus is on patients to sort of know which specialist doctor to go to. And do you think that would lead to sort of systematic sort of underdiagnosis of things? Certainly in the UK context, like specialists there they're very good with their specialism, but they wouldn't diagnose things from different body systems, or as being as good as a primary care doctor at doing that. And do you think that might contribute to differences you might observe in the UK and Japan? That lack of sort of generalists.
So yeah, I think this system has pros and cons. We have really good access to the specialty care. So in terms of so malignancy, they have really good access to the care. So I think the mortality rate of the cancer is pretty lower compared to the UK. But the system is really inefficient. So people have, for example, people have hypertension, then they want to be seen at the university hospital. They can go to the university hospital. So the specialists have to deal with those common conditions. So I think that's a problem. Also, so people with higher socioeconomic status can choose which choose a specialist or facility on their status, but people with have lower literacy, sometimes they are really difficult to find such to these.
Can I take you back to your slide, your results slide, where you were talking? It's that one when you've just gone past. Go back the one before that one. No, simply the one where you talk about the results, the increased hospitalization, and so it's the one, that one. That's the one. So when you say these things like visiting 5 or more, I'm presuming is that after adjusting for number of conditions and things like that.
Yeah.
So that's after. And do you have lifestyle information as well or not? Do you know stuff about smoking and things like that? No, you don't know. That's just interesting. Because I guess I was interested in this thing, conditions linked to polydoctoring, because I would have thought, I'm surprised there's some missing from there. For instance, I might have thought cardiology would be associated with it, heart and things and respiratory stuff. So it was interesting.
So internist covers, the whole internal problem, but so they don't see the musculoskeletal problem. So the patient on their own choose to visit orthopedics.
David?
Are you able to look at how often people are diagnosed and maybe initiated treatments or investigated for conditions outside the person's specialty? Like how often do you go and see a diabetologist, for example, and they treat your depression, or how often? Is that something you're able to capture in data at all?
So the billing code is from each facilities, so we can know which codes are billed from this facility or that facility, but we cannot. We have only a small amount of the information of regarding the specialty of the clinic, and especially in the hospital, they have multiple specialists, so it's difficult to.
I guess I was just wondering if there was some guerrilla generalism going on underneath the specialty.
So I think following on from that, I was going to, because you talk about internal medicine, and I would think of internal medicine as being a generalist specialty. I mean, except they don't do children, and they probably don't do very old, but I mean, they are. Is that not true though, in a sense, if you're going to an internist?
It depends on the region. In the rural area, internists see has to work as a generalist, but in the urban area like Tokyo, they are still specialized like cardiology clinic, and
okay,
they refer each other.
And with this new workforce, the GPs that you're training up, there's a couple of thousand a day. Is there a move to replace the specialists with the generalist primary care physicians, or how are they being integrated into this model of healthcare?
Yeah, so the government is trying to replace those specialist-driven care to the GP-led care, but about the politics. So we have big patient association composed by those primary care providers, kind of specialists. So they, opposed to the employment of the general practice-based primary care.
Stefan?
Hi, I'm Stefan. I'm a rheumatologist, so I was interested to see the internal physicians don't see arthritis. Just back to your earlier comments about the internal physicians having different roles. Does your system allow you to compare, say, rural or outside the big urban centers to the big urban centers to see how that impacts these outcomes?
Yeah, so we have the data of the kind of insurer is located in the rural or urban area. We can see that the rural and urban.
Right, we are actually at time, and so as I tend to keep things to a crime, I think if there's anybody online who's got pressing questions. If not, we will finish the session. Thank you very much for that very interesting talk. So thank you for coming along.